Good morning, students. Today I'll be starting with diseases of the uveal tract. You know as that uveal tract is very important chapter, so please be careful and listen carefully. And I'll try to put more pictures and photographs to you so that you'll understand. Okay. Accordingly, uvea, it's derived from the Latin word known as grapes. Itis is nothing but inflammation. So uvea is uveitis means inflammation of uvea. Uveal tract, it is a middle vascular layer of the eye. The uveal tract is composed of three portions: iris, ciliary body and choroid. This last time class you have heard about the anatomy. The primary function of this uveal tract is nothing but the nourishment of the ocular structures. What are the congenital abnormalities of the uveal tract? First, most congenital abnormality of the uveal tract is nothing but a persistent pupillary membrane which mimics like a posterior synechia. So it is nothing but a delicate membrane which covers the pupillary area, and it is one of the congenital abnormality. Second is congenital aniridia. Aniridia means absence of iris. So it is failure of the iris to develop. There is usually, it can be associated with nystagmus and maldevelopment of the fovea. Third is heterochromia iritis. Heterochromia is different. You know what is heterochromia? Okay, different. Iritis is in the same eye, the iris sector can be different colors. So in the same eye, the sector of the iris, the color of the iris, superiorly it can be different, inferiorly it can be different. Heterochromia iridium is one iris have different color from the other iris. Behçet syndrome is nothing but acute iridocyclitis associated with hypopyon and ulcerative lesions in the mouth. Other congenital anomalies of the uveal tract is nothing but a congenital coloboma. Coloboma is nothing but absence of the tissue. It can be iris tissue, it can be ciliary body tissue, it can be choroidal tissue. So it can be typical or atypical coloboma. Typical coloboma is always associated with, can be associated with optic disc coloboma or choroidal coloboma. Atypical, other than inferiorly, if it is associated, it is called as atypical coloboma. Congenital anomalies of the uveal tract. In this picture, in the right hand side, you can see whatever you are seeing in the picture is nothing but a clear lens which is sitting in the anterior chamber. So there is absence of iris. Congenital absence of iris is called as congenital aniridia. It can be associated with polychorias also. Polychoria is nothing but more than one pupil. Next is inflammatory diseases of the uveal tract. Uveitis is nothing but inflammation of the uveal tract. It can be divided into iritis, cyclitis. If it is involved, iris and ciliary body are involved, it is called as iridocyclitis. And choroiditis is also, it can be associated with iridocyclitis according to the specific areas of the uveal tract. Anatomical classification includes anterior uveitis, intermediate uveitis and posterior uveitis. Anterior uveitis, it is nothing but the inflammation of the uveal tissue from the iris up to the pars plicata of the ciliary body. In the last class, you know that ciliary body is divided into pars plicata and pars plana. Okay, so anterior uveitis is nothing but the inflammation of the uveal tissue from the iris up to the pars plicata of the ciliary body. This term includes iritis, iridocyclitis and anterior cyclitis. Okay, cyclitis indicate that it is the involvement of the ciliary body. Second is intermediate uveitis. It includes inflammation of the pars plana and the peripheral part of the retina. Posterior uveitis indicates it's the inflammation of the choroid. Only choroid is involved. That is called as choroiditis. Inflammation of choroid is also called as choroiditis. What is panuveitis then? Panuveitis is nothing but inflammation of all the layers, iris, ciliary body and choroid. So when whole of the uvea is involved, it is called as panuveitis. So classification as such can be divided into anatomical classification, clinical classification, morphological classification and pathological classification. And according to the duration, it can be divided into acute uveitis and chronic uveitis. Acute uveitis is nothing but a uveitis or anterior uveitis which is the duration of less than 6 weeks. Chronic is more than 6 weeks. Now, clinical classification is divided into acute uveitis and chronic uveitis. Where acute is nothing but duration of uveitis is less than 6 weeks. Chronic is at least it is more than 6 weeks and up to 3 months if the patient is having the uveal symptoms, uveitis symptom, it is called as chronic uveitis. Recurrent uveitis is nothing but the patient when the treatment has subsided, but without the subsiding of the treatment, patient has irregularly taken the treatment and he has stopped in between, then there may be recurrence of the symptoms, that is called as recurrent uveitis. Morphological classification is divided into granulomatous uveitis and non-granulomatous uveitis. Now, what is the etiological classification? Etiological classification can be divided into exogenous and endogenous. Exogenous uveitis is nothing but it can occur due to some external injury, due to foreign body or some organism which is coming from the outside. Endogenous uveitis is nothing but where uveitis is caused due to organisms from inside. Okay, if the patient's immunity is reduced, for example, in an HIV patient or tuberculosis patient, where immunity is reduced, so they develop uveitis due to septic foci present elsewhere in the body. It can be in the bloodstream, which causes the irritation of the uveal tract due to sensitization. So, etiological classification is nothing but exogenous uveitis. Exogenous uveitis is caused by either external injury to the uvea by the invasion of the microorganisms or other agents from outside. Endogenous uveitis is caused by the microorganisms or the other agents from within the patient. So you may be seeing when you come to the clinical side, you'll be seeing that patients are referred to ophthalmology department from medicine, tuberculosis, TB and chest department, or maybe some other department due to they want the patients to be tested in OPD for uveitis. So anterior types, iritis is nothing but inflammation, primary. So you should be clear with this. Iritis is nothing but inflammation involving only iris. Iridocyclitis is nothing but the inflammation of iris and the ciliary body. Intermediate uveitis is nothing but the inflammation involving only the vitreous. So what are the main symptoms of anterior uveitis? So patient will always come with pain, redness, photophobia and lacrimation and along with blepharospasm. We should always differentiate any patient coming with red eye to see whether any iris or ciliary body is involved. So uveitis signs are very important when any patient coming with red eye. Now, what are the differential diagnosis for your red eye? What are the differential? One is your iridocyclitis. Second one, it can be your keratitis. Third one, it can be your acute congestive glaucoma. So always remember, circumciliary congestion, there are three conditions. One is your iridocyclitis. Second is keratitis. Third is your acute congestive glaucoma. So in our patient in iridocyclitis, the patient will present with pain, redness, photophobia, lacrimation and blepharospasm. Always pain is the dominating symptom of acute anterior uveitis. Patient usually complain of dull, aching, throbbing sensation pain, which is usually worse at the night time. So this is a picture. You can see there is an involvement of superficial as well as deep vessels are involved. This is called as circumciliary congestion. What are the important signs of iridocyclitis? So important signs of iridocyclitis is always there is a involvement of periorbital edema can be there or lid edema can be there. There is circumciliary congestion and there is always ciliary pain. Severe pain will be there. That is called as ciliary pain. What are the signs you see in cornea, which is very important? Okay. Kertic precipitate, they can ask you for 5 marks always or they may ask for 3 marks. So you remember whenever they ask for kertic precipitate as short notes, please try to write everything about what are the kertic precipitate, what are the types of kertic precipitates, and where all you see, and you can just draw a diagram. Okay. So in corneal signs, you can see keratic precipitates are nothing but a cellular deposits which are present on the corneal endothelium. Okay. Keratic precipitates nothing they are the cellular deposits which are present on the corneal endothelium. They can be seen on the back of the cornea and the inferior part of cornea. Why? Why they are always seen there? Because of Tyndall effect they can be seen, or it can be due to gravity. Because of gravity, they tend to sit down in the inferior part and the back of the cornea. Okay. There are different types of keratic precipitates. They can be keratic precipitates are two types. They can be fresh keratic precipitates, or they can be old keratic precipitates. How do you differentiate keratic precipitates? I told they are always present in the inferior part of the inferior part of the cornea and the back of the cornea. Okay, keratic precipitates, they are present. Why? Because of the gravity. Okay, and they're always arranged in the form of arch triangle, or they are present in the form of triangle, that is called as arch triangle. Arch, ARTLS. You have seen arch line in your trachoma. Okay, so keratic precipitate also are arranged in the form of arch triangle in the inferior and back of the cornea. So fresh capes and old capes, how do you differentiate? Fresh keratic precipitates are white, round, and they shrink. Okay, white, round, and they have a crenated margins. Okay, when they become old, they become pigmented, they shrink in size. So this is the way they have to differentiate fresh keratic precipitate from old keratic precipitate. मैसेज बनते स्टॉप ಈಗ ಸ್ಟಾರ್ಟ್ ಆಯ್ತು ಸ್ಟಾಪ್ ಆಗಿದೆ ಅಂತ ಯಾರು Okay, sorry for the interruption, students. Okay, so I was telling about keratic precipitates. Okay, they are nothing but the cellular deposits which are present in the inferior and the back of the cornea. They can be fresh capes, old capes, and there are different sizes also. They can be small to medium sized capes, and they can be large capes also. Small to medium sized capes or keratic precipitates are seen in non-granulomatous uveitis. Large or mutton fat capes are always seen in your granulomatous uveitis. What are the granulomatous uveitis? That was seen in cases of tuberculosis, leprosy, sarcoidosis. Okay, in the right hand side you can see those capes. They are inferiorly, in the above figure you can see small to medium size. Inferiorly the picture you can see there are small capes. These four pictures in the left hand upper side you can see they are moderate or small to moderate size of capes. In the right hand side you can see they are also small to medium size capes. In the inferiorly the left hand you can see the iris nodule picture which is sitting on the iris. Okay, in the collarate of the iris you can see those, that is nothing but a iris nodule. In the right hand side inferiorly, you can see there is a exudative membrane which is present in the whole of your pupillary area is involved with exudative membrane. Okay. So you know about KPs now, types of KPs, sizes of KPs. Next, what you can see in iris. So iris, you should always remember when there is or acute iridocyclitis, iris pattern will be lost due to waterlogging of in the iris. Okay, and there can be edema. Due to edema and waterlogging within the iris, there can be loss of the iris pattern. So it appears normally iris is muddy. Okay, so it can, because of that, it can, otherwise you should tell normally it is normal crypts and cryptations are present. In cases of iridocyclitis or acute uveitis, there may be loss of iris pattern. Though you cannot see crypts and cryptations, it becomes more of muddy in picture. Okay, in cases of active phase, and it may show, and later on of long standing cases you can see there is loss of pigmentation also. There can be depigmentation, hypopigmentation. Okay, so in iris you can see loss of normal pattern due to edema and waterlogging. It becomes more muddy in color during acute phase and may show hyperpigmentation and depigmentation areas in the heal stage. So in this picture you can see there is a thick membranes are there at 7 o'clock, 8 o'clock, 1 o'clock, 2 o'clock. Okay, and the pattern of the iris is, you can normally the iris is not like this. They will have crypts and cryptation, but here there is pigmentation. In some places there is hypopigmentation. In some places there is dispersion of pigments on the pupillary area. Okay, this is nothing but a full blown case of acute iridocyclitis. What do you see in the anterior chamber? Now you finished your cornea. Okay, you finished your iris. Now you are seeing about anterior chamber. Anterior chamber, you should always remember, there can be, normally it is clear. Anterior chamber is about 2.5 millimeter to the diameter, depth of the anterior chamber is 2 to 2.5 millimeters. So if at all, it will be always clear, crystal clear it will be. If it is turbid, it is always due to uveitis. Okay, otherwise it is always clear. And it is normal depth. Okay, in case of iridocyclitis, it can be deep anterior chamber. Okay, so always remember, if there is a hypopion, it is nothing but a sterile pus in the anterior chamber. Hypopion is nothing but sterile pus in the anterior chamber. Sometimes, why there is hypopion? It is nothing but it is due to exudates, due to antigen and antibody reaction. There can be formation of exudates, which is seen in the anterior chamber in the form of hypopion. Then what is hyphema? Hyphema is nothing but blood in the anterior chamber, which is always seen due to injury. If at all you have an injury, there may be blood in the anterior chamber, or hyphema is also seen in cases of viral iridocyclitis. So always remember, if you see a blood in the anterior chamber, it is due to your injury, or it can be due to viral iridocyclitis, like your herpes infection. Okay. What is hypopion? Hypopion is nothing but a sterile pus in the anterior chamber. It is due to exudate which settle down in the lower part of anterior chamber due to antigen and antibody reaction. Hypopion can also be seen in your corneal ulcers. Okay, and it is also seen in your cases of Behçet's disease. Okay, it is type of intermediate uveitis. So hypopion, it can be it is always seen in iridocyclitis, or it can be seen in your keratitis also. Okay. Next is an anterior chamber. What you are seeing in anterior chamber is, one is hypopion, hyphema. Then what are the other changes you see in your aqueous humour? What are the changes you see? So many changes are happening in your anterior chamber. I told it will be clear. If it becomes turbid due to antigen and antibody reaction, it indicates that there is a AC reaction in your anterior chamber. So what type of active inflammation is going on in the anterior chamber is nothing but it is called as aqueous flare. What is aqueous flare? It is nothing but a result of the leakage of proteins into the aqueous humor through the damaged blood vessels, which always indicate it's a type of active inflammation. Always remember, Aqueous flare is the first important earliest sign which occurs due to iridocyclitis. Okay. Okay, aqueous flare is the important sign and it is one of the earliest sign which you seen in iridocyclitis. So in anterior chamber, what you are seeing, what are the changes is happening? One is it can be hypopyon can be there, it can be hyphema can be there, or even aqueous flare is one of the important sign which indicates the result of leakage of the proteins into the aqueous humor through the damaged blood vessels. Okay. In the right hand side, in the above picture, you are seeing what is there is a hypopyon. In the inferiorly, you can see there is a turbid fluid in the anterior chamber. That indicates that there is aqueous flare. Okay. So you remember sometimes in your UG exams, they have asked grading of the aqueous flare for 3 marks question. So please note down this also. So anterior chamber signs, one is aqueous cells can be seen, second is aqueous flare. Aqueous cells can be counted by the oblique slit lamp beam. So if aqueous cells, if there are less than 5 cells, then it can be grade plus or minus. 5 to 10 cells, you grade it as plus 1. 11 to 20 cells can be graded as plus 2. 21 to 50, it is graded as plus 3. And more than 50 cells, you always grade it as plus 4. Okay, accordingly, aqueous flare, faint just detectable aqueous flare is plus 1. And moderate iris details when it is seen, it is plus 2. Marked iris details when it is hazy, it is plus 3. Intense with fibrinous exudates, it's called as plus 4. Aqueous flare, it is due to leakage of proteins in the aqueous through the damaged capillaries, causing that a Tyndall effect. Okay. Hypopyon is nothing but a sterile pus in the anterior chamber, which is classically seen in Behçet syndrome. Hyphema is blood in the herpetic and traumatic uveitis. I always tell in my class, where do you see aqueous flare? Okay, so I think if you people have gone to your villages and all, so you'll be seeing in the kitchen that you'll have a chimney. The villages, it is always a dark space. In the kitchen, they have a chimney. So when you close all the doors and you open your chimney, you see that a Tyndall effect like light will be falling on the inferior part of your floor. So wherever the light is falling, you can see the dust particles are arranged in the wherever the light is coming from your chimney. So this is nothing but a aqueous flare. When you see in the oblique slit lamp, you see the arrangement of the dust particle is in the form of where you see it is like in your kitchen or in the villages where you have a chimney, that even the aqueous flare has a typical arrangement when you see in the slit lamp. Okay, then what are the other changes you see in your iris? You should always remember there is a posterior synechiae. What is posterior synechiae? Posterior synechiae are nothing but an adhesion between the posterior surface of the iris and the anterior capsule of the crystalline lines. These are formed due to organization of fibrin, which profuse in the exudates, and synechiae can be segmental, annular, or total. Posterior synechiae is nothing but adhesion between the posterior surface of the iris and the anterior capsule of the crystalline lens. Okay, the synechiae can be segmental, annular, or it can be total. When there is a formation of posterior synechiae at few points, like 1 or 2 points, it is called as ring synechiae. When there is a formation of posterior synechiae with totally a 360 degree, it is called as occlusive pupillae. Okay, and when there is a formation of posterior synechiae with occlusion of your pupil, preventing the drainage from the posterior chamber to anterior chamber of the aqueous, then it is called as occlusive pupillae. So you should always remember what is occlusive pupillae and occlusive pupillae. This also can be asked for your 5 marks question. Okay, in occlusive pupillae, there is a formation of the exudative membrane, 360 degrees formation is there, but inflammation as such is not started. It is inflammation only, due to inflammation it is there, but the drainage of aqueous is not blocked. So it is ring synechiae at 360 degree, it is called as occlusive pupillae. Occlusive is where it is occluded and there is a blockage of the drainage from the posterior chamber to the anterior chamber, that is occlusive pupillae. Okay. This is a picture of acute anterior uveitis. where you can see the pupil is irregular. Normally you have a small regular reacting 3 to 4 millimeter of size of the pupil. It becomes irregular in size, okay, and you can see posterior synechial, broken synechials at so many places at 11 o'clock, 12 o'clock, 1 o'clock, 5 o'clock, 7 o'clock and 9 o'clock. So whenever you want to break the synechial, then you have to use your cycloplegics. What are the pupillary signs? So total posterior synechial, it is due to plastering of the total of the iris with the anterior capsule of lens is called as occlusive pupillae. And in the pupillary signs, you should always see what I told you is pupil is becomes small in cases of acute iridocyclitis. Normally pupil is 3 to 4 millimeter normal regular reacting to light. It becomes very sluggish, small in size, okay, and it's when you put the torchlight it reacts very sluggishly. It indicates due to edema. I told you, due to edema and waterlogging it becomes more muddy, okay, and iris becomes more muddy, and when you put torchlight pupil becomes, it reacts very sluggishly. It is due to waterlogging or irritation of the sphincter pupillae by the toxins, okay. So irregular pupil shape also results in the segmental posterior synechial formation. So at this stage, when there is a synechial, you want to break the synechial, you have to dilate the pupil to break the synechial. Why? Why you want to break the synechial? Otherwise, it causes iris bombae. That is, there is a blockage of your drainage from the posterior chamber to anterior chamber. So there is ballooning of your iris forward to form a iris bombae picture. This to prevent that, you have to dilate and break the synechial. How do you break the synechial? You have to use cycloplegics like homide or atropine. Okay. Along with this, sometimes there can be even anterior vitreous cells in the anterior chamber. Okay. This is a picture of acute anterior uveitis where you can see a posterior synechial and the shape of the pupil is like a garland shape. Means it is not round, it is irregularly somewhere, so many pointings are there at 1 o'clock, 2 o'clock, 3 o'clock, 4, 7 and 11 o'clock. So that is garland shape. This is called as festooned pupil. Okay, when you break the synechial with your anticycloplegic, so the shape will not come, it doesn't become round, it becomes irregular. This is called as festooned pupil. Okay, so now I want to tell you what are the signs of acute iridocyclitis. Signs of acute iridocyclitis, always remember there can be lid edema, periorbital edema, circumciliary congestion, or that is superficial and deep congestion is called as circumciliary congestion. There is severe corneal edema with keratic precipitates, okay, in the cornea. In the anterior chamber you are seeing hypopyon, hyphema. Accordingly, if it is a uveitis, if you see a viral uveitis, it can be a hyphema or it can be a besides you can see a hypopyon, okay, or if it is in keratitis also you see hypopyon. So in anterior chamber you are seeing what all you are seeing? You are seeing hypopyon, it can be hyphema, or it can be always see aqueous cells are there, flare is there, okay. In cornea you are seeing keratic precipitates, okay. Then iris, what is that? Normal iris pattern is lost. It becomes more muddy in case of iridocyclitis. When and it is going into chronic uveitis, the picture is different. So you can see hypopigmented patches of iris, or it can be depigmented patches of iris will be there. Iris pattern is fully lost. Okay. Then you can see in acute iridocyclitis, the iris is very sluggishly reacting. Okay. Pupil is very sluggishly reacting, pattern is lost. Okay, in acute iridocyclitis, use muddy iris will be there. Okay, then pupil different shape. We can see a posterior synechial, you can see a segmental, annular or ring synechial, you can see a occlusive pupillae, then occlusive pupillae, leading to iris bombae. Okay, okay. Now what are the causes of granulomatous uveitis? So causes of granulomatous uveitis are sarcoidosis. I always tell in the class that you should always remember only four. Don't try to remember all the causes for granulomatous uveitis. Only four you can remember. Four can be your tuberculosis, leprosy, sarcoidosis, okay? And you can always remember your Vogt-Koyanagi-Herdus disease, if at all. Otherwise, you remember tuberculosis, sarcoidosis, and leprosy. Only three you can remember, okay? What are the causes for non-granulomatous uveitis? Causes for non-granulomatous uveitis are idiopathic. First, always you should remember the cause first is idiopathic. Second can be your allergy. Third can be any other causes associated with HLA-B27. Okay. Try to remember only 3 diseases, otherwise it's very difficult to remember all the causes. How do you differentiate now granulomatous from non-granulomatous uveitis? This is also one of the classification for clinico-pathological, which I was telling you. Okay, anatomical classification, clinical classification, and duration also you have, and morphological classification. So this question they were asked several times. Granulomatous uveitis, the onset is always insidious. Eye is always white because it's always runs in a chronic diseases like your tuberculosis, leprosy, sarcoidosis. And in non-granulomatous uveitis, the eye is always red because it has very less duration. Due to it can be allergy or idiopathic. So it's a short duration. Okay, in granulomatous, the duration is chronic. In granulomatous uveitis, your capes are small, medium, and large mutton fat capes are seen. In non-granulomatous, you always have a small capes. Aqueous flare is very slight in cases of granulomatous uveitis. In non-granulomatous uveitis, in aqueous flare is very intense. Thick, intense aqueous flare is seen. Capes, and in cases of granulomatous uveitis, you have iris nodules that are called as copaceous nodules, which are seen in the pupillary margin, and Busaka's nodules are which are seen in the collarate. Those type of iris nodules are not seen in your non-granulomatous uveitis. Okay, you have a dense, broad, very thick posterior synechiae in cases of granulomatous uveitis. In non-granulomatous uveitis, there is no posterior synechiae at all. It doesn't cause so much of inflammation. Okay, because I told the common causes for that is allergic and idiopathic. So those severe inflammation is not there in cases of non-granulomatous uveitis. Granulomatous, you have very dense posterior synechiae. Aqueous flare is very less. Okay, and in case of granulomatous uveitis, it affects all the layers. Okay, iris, ciliary body, choroid, everything will be in. But in case of non-granulomatous, normally it involves only the anterior part of the uvea. Okay, iris and sometimes ciliary body can be involved. In case of granulomatous uveitis, you can see heavy vitreous exudates. So all layers are involved, so you can see even vitreous involvement are there. In cases of non-granulomatous, you have fine punctate opacities in the vitreous. Etiology is always direct. All the organisms, as such I told, organism infection is very common in granulomatous, and in non-granulomatous it is common as allergy. Complications are many more, and it is very difficult to treat in case of granulomatous, and non-granulomatous it is few complications. What is the etiology? The most cases it remains obscure. Okay, the etiology, we don't know what is the cause. We have to find out the cause. First is always, you should always remember, is the infections. It can be exogenous. Organisms will reach the eye from outside. It due to perforating injury, or due to perforating corneal ulcer, or due to following any operation, intraocular operation. This usually leads to some superior iridocyclitis, can lead to endophthalmitis, even panophthalmitis. Secondary, it can spread from one or the other ocular tissue. Like if corneal ulcer is there initially and that patient is not responding properly, that is also involved the uvea, or secondary to some scleritis. It is involving later, it is involving even uvea also. Third is the endogenous. Organisms primarily lodge in some other organ of the body such as eye. From the bloodstream, it is reaching the uvea. Okay, so you know uvea is highly vascular structure. Okay, so it can involve due to any of the exogenous or endogenous infections. Viral infections are due to herpes simplex, herpes zoster, measles, mumps, rubella. Bacterial can be your tuberculosis, syphilis, leprosy, gonorrhea, brucellosis. Fungal is histoplasmosis, aspergillosis, candida albicans, actinomycetes. Protozoal can be toxoplasmosis, nematodes can be ankylostomosis, filariasis. Second commonest is allergy. Allergy is again bacteria, TB, usually of lungs, lymph nodes leading to again uveitis, or teeth infection due to streptococcal, tonsil infection, sinus infection, urogenital tract, again it is leading to again uveal involvement. So primary source of infection, it can exist at any of these sites, okay, in the lungs or the teeth or some caries in the tooth, that is again causing an infection in your uvea due to sensitization. At one time, the infection was generalized by the escape of the organisms into the bloodstream when the ocular tissue like uvea had been sensitized to them. At the later date, further dissemination of the organisms or their proteins meeting the sensitized uvea tissue excites an allergic response. So because of that, even the lens protein sensitization, it causes phaco-anaphylactic reaction. What is this phaco-anaphylactic reaction? Is after cataract surgery, you are left your cortex, which is in the, maybe there is a PC ring and there is a, the cortical matter has gone into the vitreous. Later on, and you are operated nicely, put the lens, everything and gone home. Okay, later on, after 1 month, the patient may come with mutton fat, KP, circumciliary congestion, corneal edema with so much of reaction. Then you will be thinking why everything is fine, why there is so much of reaction. So this may be due to your lens protein irritation. Okay, so because of that, that is called as phaco-anaphylactic reaction. Anaphylaxis due to lens proteins. Okay, third is uveal pigment. It causes sympathetic ophthalmitis. Sympathetic ophthalmitis due to injury. You are sutured your there is iris prolapse and you are sutured along with your iris. Involving the iris, you are sutured. So because of the sensitization of uveal pigment, there may be sympathetic ophthalmitis, which is nothing but a type of panuveitis. This sympathetic ophthalmitis, later on I'll deal with it. Okay, if at all patient has others, like some other illness also, if the metabolic status is not good, so they are more prone for severe type of uveitis also. If the constitutional diseases are there like diabetes, gout, rheumatoid arthritis, like ankylosing spondylosis, they are more prone for uveitis. So even trauma like blunt injury and all, they are more prone for uveitis. Idiopathic is sarcoidosis, Vogt-Koyanagi-Herdus disease, Behçet's disease. Miscellaneous can be intraocular hemorrhage, intraocular tumor. So pathology here is inflammation of iris and ciliary body have the same characteristic as other vascular connective tissue. That is the cause for your uveitis. This is one of your differential diagnosis for your iris nodule. Like you have iris nodule in case of uveitis, you have other nodules like tuberous nodule, syphilitic nodule, leprosy nodule, sarcoid nodule, ophthalmia nodosa. In tuberculosis nodule, the iris is color of that nodule is gray or yellow. Avascular capillaries will be present. In syphilitic, it can be yellowish red avascular. Leprosy, it is pale avascular. Sarcoidosis nodule, it is reddish vascular capillaries are present on the nodule. Ophthalmia nodosa, I think it is covered in your conjunctival chapter. It is due to sensitization due to hair of the caterpillar. So tuberculosis nodule location is always seen in the pupillary and ciliary zone. Syphilitic nodule is seen in pupillary or ciliary zone, and in leprosy also pupillary. Sarcoids can be anywhere, and progress is slow. Syphilitic nodule, it is grow relatively quickly. Leprosy nodule, it can grow slowly. Sarcoidosis nodule, it can grow very slowly, and even ophthalmia, it grows very slowly. Now, what are the complications of your anterior uveitis? So complications can be your secondary glaucoma, which is very important. Okay, this is due to clogging of the trabecular meshwork by the inflammatory exudates, which is called as plasmoid aqueous. So aqueous become turbid, plasmoid. Otherwise, it is clear. Okay, so it can be secondary glaucoma. It can be due to one of etiology for that is clogging of this material trabecular meshwork by the exudates. Second, it can be due to seclusive pupillae. What does the seclusive pupillae cause? It doesn't, it causes, I told it, blockage of the trabecular meshwork produces the iris bombae, which gives rise to peripheral anterior synechiae. Fourth is due to occlusive pupillae. Fifth is due to increased capillary hydrostatic pressure, which is leading to an increased aqueous formation. So these are the etiology for your secondary glaucoma. What are the etiology? One is clogging of the trabecular meshwork. Second is occlusive pupillae or due to occlusive pupillae, increase in the capillary hydrostatic pressure. Second complication of your anterior uveitis is complicated cataract. Third, what are the complications you see in cornea? Cornea opacity may result due to posterior. I told there is severe corneal edema because of rays in the IOP. There can be due to rays in the IOP and corneal edema. It causes persistent edema. The edema will not disappear. It becomes persistent edema. Okay. Second complication which occurs in cornea is band-shaped keratopathy can be seen in cases of stasis. Third is retrocorneal membrane can be formed due to organization of exudates behind the cornea is called as retrocorneal membrane. Any membrane which is formed due to exudates which is behind the cornea is called as retrocorneal membrane. Fourth complication is cyclitic membrane. It is the membrane which is formed in the anterior vitreous behind the lens due to organization of the inflammatory exudates. Okay. Fifth complication is retinal detachment. So what are the complications of your uveitis? First commonest complication of this is secondary glaucoma. Second is complicated cataract. Third is in cornea. You can see corneal edema, persistent corneal edema there. It can be there. Retrocorneal membrane can be there. Fourth is cyclitic membrane formation can be there. Then the cyclitic membrane, what does it cause? What is the significance of the cyclitic membrane? It causes diminution of vision. Okay, causes a contraction of that cyclitic membrane and leads to retinal detachment. Okay, and fifth is retinal detachment. Retinal detachment, what? It is due to the contraction of the cyclitic membrane causes retinal detachment. It can be exudative type of retinal detachment when iridocyclitis is associated with choroiditis. So this is the picture of a RD. Inferiorly, the normal retina, you can see optic disc. You can see the optic disc with vessels. Above the retina is not clear. Okay, there is lot of fluids accumulation along with some white lines, which indicates is a type of retinal detachment. It is a fresh retinal detachment. Sixth is thysis pulpi. Okay, why there is thysis pulpi? It is due to damage to the ciliary body due to organization of the exudates on the surface. Contraction of the cyclitic membrane detached the ciliary body. This results in the decrease in the production of the aqueous, leading to the ocular hypotony and thysis pulpi. Okay, so what are the complications of your uveitis? First is your secondary glaucoma, and you in the cornea you can see there can be corneal edema, persistent corneal edema, there can be band-shaped keratopathy, there can be retinocorneal membrane. Third is your cyclitic membrane formation can be there. Fourth, there can be a complicated cataract. Fifth can be a retinal detachment. Sixth is your thysis pulpi. So you should always remember, please, whenever they ask, they can ask clinical feature of anterior uveitis. What are the investigation? How do you treat with complication? This is 10 marks question. So you have to write everything from starting from today's class, what all I have dealt. Okay. Then thysis pulpi, it occurs due to contraction of the cyclic membrane which can detach the ciliary body, which results in the decrease in the aqueous production, leading to ocular hypotony and thysis. The right eye is normal, left eye you can see it is eye is small, but their architecture is maintained. That is, but even then you cannot see it is very small. So that indicates it is thysis pulpi. There is one of the Viva questions. You should know what is thysis pulpi and atrophic pulpi. Now, what is the differential diagnosis for acute red eye? I was telling it is acute conjunctivitis. Differential diagnosis for red eye: acute conjunctivitis, acute iridocyclitis, acute congestive glaucoma. So, in acute conjunctivitis, pain is it can be it has a foreign body sensation or gritty sensation. In iridocyclitis, it is pain radiating along the first division of the ophthalmic division of fifth nerve. In acute congestive glaucoma, there is severe neurologic pain which is radiating along the third division of fifth nerve associated with nausea and vomiting. In acute conjunctivitis, vision is not affected. It can be slightly blurring of vision can be there because of discharge, mucopurulent discharge. In case of acute iridocyclitis, the moderate diminution of vision is there. Okay, so when you see gross diminution of vision, you should always remember it is due to congestive glaucoma only. It can be even reduced to perception of light only. Okay, in acute conjunctivitis, you have mucopurulent discharge. In acute iridocyclitis, there is watery discharge. In acute congestive glaucoma also, you have a watery serous discharge. In conjunctivitis, you have a normal superficial congestion. Okay. In cases of iridocyclitis and congestive glaucoma, you have circumciliary, that is superficial as well as deep congestion is involved. Corneal sensation is normal in case of conjunctivitis. In iridocyclitis, there can be edema, KPs are seen, but then sensation is not lost. But as well as in congestive glaucoma, there is severe corneal edema because the IOP is very high. Anterior chamber depth is normal in conjunctivitis. In case of iridocyclitis, you can get a deep anterior chamber. I told you you get a deep anterior chamber. Shallow anterior chamber is seen in your glaucoma. Okay. Pupil size is normal, reacting to light in case of conjunctivitis. You get a small, sluggishly reacting irregular pupil in cases of iridocyclitis. You get a large, vertically oval fixed pupil in cases of glaucoma. IOP is always normal in case of conjunctivitis. IOP can be low or it can be very high or it can be normal in cases of iridocyclitis. It is always markedly raised, stony hard in cases of glaucoma. Ciliary tenderness is absent in cases of conjunctivitis. In iridocyclitis, ciliary tenderness is present. In cases of glaucoma, it is absent. So always acute iridocyclitis should also be differentiated from other causes of red eye like corneal ulcer and scleritis. So how do you investigate this case? Routinely, like all the cases, you have to do routine hemogram, CBC, okay? With routine hemogram is very important. Serological test, VDRL and FTA, fluorescent FTA and ABS for syphilis. Skin test is Mantoux test is for tuberculosis. Weem test is a specific test. It is for sarcoidosis. X-ray, it is chest and joint X-ray. And urine examination are very important. Treatment, what is the main, how to treat this uveitis? First, what you want to do when you diagnose the case, you have to prevent the vision threatening complications. You have to prevent. To prevent the vision threatening complications is the main aim for your treatment of uveitis. Second, to relieve the patient's pain and discomfort. Third is to treat the underlying cause. So what are the non-specific treatment is short-acting tropicamide 0.5 to 1% cyclopentolate phenylephrine are used, but in our practice we use homide, okay, TID homide is used and cyclopentolate we use, and even atropine in cases of severe posterior synechia is there, you want to break the synechia, then you use even atropine also is used. Okay, and the second is subconjunctival injection 0.25 ml of midricane, atropine, adrenaline, procaine. Please remember this, what is this, okay? So when there is a posterior synechia which is refractory to break, there is 360-degree posterior synechia, even with your highest midriatic or cyclopentolate or atropine we are using, but there is synechia, we are not able to break the synechia. In that situation, you have to give an injection that is called as midricane injection. What is midricane? Midricane is nothing but atropine, adrenaline, procaine. 0.2 ml of atropine, adrenaline, procaine is called as midricane injection. So we want to give this, when we give this subconjunctival injection of this midricane, then you can break the synechia. Okay. Then what are the treatment for steroid treatment? Topically, you can give a drops or ointment, but we normally give oral tablets only for intermediate uveitis, okay? But we give topical steroid normally. We use prednisolone drops are used, okay? 1 drop hourly depending upon the inflammation. But for theoretical purpose, you can write like this topically as drops or ointment, dexamethasone, betamethasone and prednisolone. In our practice, we are using prednisolone. Second line of treatment is periocular injection. Tissue plasminogen activator, triamcinolone, methylprednisolone acetate. This all it is important in cases of your intermediate and posterior uveitis. But in anterior uveitis, normally you can give only topical steroids. Intravitreal injection, systemic therapy and all is not necessary. Okay, the main line of treatment for acute iridocyclitis from today's class, you should understand that only steroid. Please don't write antibiotics for this treatment. The treatment for acute anterior uveitis is always steroids along with mydriatics. Okay. NSAID can be given whenever there is rheumatic type of uveitis. Otherwise, there is no role of NSAIDs in this. What are the treatment for complications? If so, there is secondary glaucoma, then you have to reduce the glaucoma, to reduce the IOP, you have to give tablet Diamox, timolol malate eye drops can be given. And you should remember in case of uveitis, you should never use prostaglandins, which is contraindicated in this case, and even pilocarpine is contraindicated in cases of uveitis. So in complicated cataract, if due to uveitis the patient has developed cataract, then you have to do what is the treatment is at least you should do lens extraction, but eye should be quiet at least for 3 months. Okay, the patient, the eye of the patient, that is, it should be free of inflammation. There should not be flares, cells, and all. At least for 3 months, if eye is quiet, then that patient can be taken for cataract surgery. But why? You know, it is very highly vascular structure. It causes so many complications. There can be formation of cyclitic membrane. There can be formation of RD. There can be formation of thysis also. Even if there is inflammation and we want to operate with the inflammation, first of all, it will not dilate. You know that pupil has become irregular. There is a synapse. You cannot break the synapse and you cannot extract the lens. Okay, it is very tricky to operate in this situation. In retinal detachment, if exudative type of RD will settle down in itself, the uveitis is treated properly. If tractional type, then vitrectomy should be done. Okay. Now today I will stop here. Thank you very much, students. Tomorrow I will start with intermediate uveitis and posterior uveitis. Thank you, madam. Thank you, madam. ಅವರಿಗೆಲ್ಲ ಇಷ್ಟ ಆಯ್ತು ಅಂತ ಪ್ರೆಸೆಂಟೇಷನ್ ಅಪ್ಲೋಡ್ ಆಗಿದೆ ಅಲ್ಲ? ಆಗಿದೆ. 225 attendance.